Welcome to another CME podcast from NEI, the Neuroscience Education Institute. In today's CME episode, Dr. Andrew Cutler will be interviewing Dr. Larissa Mooney about today's challenges with using medication for the treatment of opioid use disorder. For complete CME information, please refer to this podcast description page or go to nei.global/podcast. Let's listen in as Drs. Cutler and Mooney discuss the current research on treating and managing opioid use disorder.
Welcome to another NEI podcast. I'm Dr. Andrew Cutler, Chief Medical Officer of NEI, and it's really my pleasure today to have a colleague, Larissa Mooney, with us. And we're going to be talking about overcoming barriers and challenges to the treatment of opioid use disorder. Larissa, welcome, and thank you for joining us.
Thank you for having me.
I'm going to sort of jump in here with a question about historical nature. And first of all, I understand that the terminology is constantly evolving, and some of our listeners may be familiar with the mnemonic MAT, medication-assisted treatment, but I understand there's newer terminology, isn't there?
Yes, the field is starting to move away from the term MAT, medication-assisted treatment, to just say medication treatment or medication treatment for opioid use disorder. Mm-hmm. And this has to do with the connotation of medication-assisted treatment, suggesting that these medications should only be used in conjunction with behavioral treatment, or maybe even that there's an implicit suggestion that their use may make recovery less than true recovery that might happen without medication. And we know that these medications really have a robust effect. They can be combined very nicely with behavioral treatment, but a robust effect even if they're used independently.
Of course, this is a very topical topic, if I could be so alliterative, because during the COVID-19 crisis, we're all aware that the substance abuse and substance use disorders have increased pretty dramatically, haven't they?
Absolutely. There's data showing that substance use is on the rise, as well as overdoses from substances during COVID.
Oh my, overdoses as well. I know also that suicide rates are rising, and I suppose accidental deaths, which would be the more appropriate term for overdoses. Mm-hmm. Mm-hmm. Okay, historically, I'm sure everybody's familiar with methadone. Which of the medication treatments for opioid use disorder came about first? Was methadone the first one?
Methadone was the first one. We've had methadone around the longest as an approved medication to treat opioid use disorder. In the case of methadone for opioid use disorder, however, it can only be dispensed from federally licensed clinics.
Federally licensed, I see.
As apart from its prescription for pain, for example.
Yeah. Oh, I see.
It can be done in an office-based setting.
Got it. And with respect to medication treatment here, is buprenorphine as effective as methadone?
Yes, the short answer is yes. Buprenorphine is as effective as methadone. There have been multiple randomized trials that have directly compared buprenorphine to methadone treatment, looking at outcomes such as illicit opioid use and treatment retention. And both treatments are equally effective at reducing illicit opioid use, but methadone may be slightly more effective at retaining patients in treatment, particularly if doses are given in a flexible dosing schedule.
I see. Of course, there's many preparations of buprenorphine. I sometimes get a little confused by them.
Yes, there are a growing number of buprenorphine formulations. Many of them are transmucosal. Buprenorphine is bioavailable transmucosally. The formulations are often administered sublingually and actually in combination with naloxone, which isn't bioavailable transmucosally. However, it's there as a deterrent to parenteral misuse of the medication. So if someone crushes and injects the buprenorphine naloxone, the naloxone is present and able to block the effects of other opioids in the system.
Well, that is pretty sneaky. I like that.
Yes. And then there's also actually an implant formulation that releases buprenorphine slowly over 6 months, and more recently approved subcutaneous monthly injectable formulation of buprenorphine as well. So these are formulations that can help with adherence and minimize diversion of the medication.
Yeah, so there's a lot of options here, obviously, which is great, I guess, for both the prescriber and the patient.
It helps us with, individualizing care and having options. If one treatment isn't working, we could consider switching to a different formulation or a different treatment altogether because we have a few FDA-approved medication options now.
Right, and that gets me into the next topic, which is I wanted to talk a little bit about naltrexone, which is another available treatment.
Mm-hmm.
And I understand there is oral preparation and there's a long-acting injectable as well.
Yes, there's a 50 milligram oral tablet or a 380 milligram extended release monthly injectable formulation that is administered in the deep gluteal muscle once a month. And that is actually the preferred option for treatment of opioid use disorder in particular. These are also approved medications for alcohol use disorder as well.
Mm-hmm. And why would you say that the long-acting injectable is the preferred medication?
It's preferred primarily because of adherence. Adherence to oral naltrexone is generally poor, with a lot of early dropout, and it is more effective in reducing relapse to opioid use, reducing cravings, and also improving retention and treatment.
So the LAI versus the oral naltrexone, you're saying, is clearly superior?
Yes, for opioid use disorder, that is the strong recommendation in terms of formulation.
Now, how would a clinician choose between naltrexone injection and one of the buprenorphine preparations?
That's a great question. Thinking about, what patients might be appropriate, how to select different treatment options, given that we do have these different options for treatment. And there's a few factors that I think about when considering choices of medication. One is, of course, patient history. What have been their prior trials, their prior experiences on the different medications? Have they not done so well on one of them? In which case, this might be an opportunity to try a different medication. In the case of naltrexone, it's also approved for alcohol use disorder, as I mentioned. So an individual who also has co-occurring alcohol use disorder and isn't anticipated to have the need for full opioid agonist treatment for acute pain could be a good candidate for naltrexone, for example. But it's an opioid antagonist, so it's going to block any exogenously administered opioids.
Well, that is, of course, the major distinguishing factor, isn't it? The buprenorphine is a partial agonist, whereas naltrexone is an antagonist. So
Exactly. And buprenorphine as an office-based medication option is usually fairly easy to initiate in an outpatient setting in multiple different healthcare settings. And it doesn't have the restriction, for example, of methadone only being dispensed in federally licensed clinics. So buprenorphine is commonly used, but naltrexone is another option for opioid use disorder. However, there's some challenges getting patients onto naltrexone because they have to be opioid free for about a week before starting that induction.
I see. So what's the best way then to initiate? How would you negotiate that?
Yeah, I would have a conversation with the patient about the different options and how they work, because they have different mechanisms of action and different pros and cons like everything else. And in the case of naltrexone, the prescriber would have to be comfortable arranging the induction process, which would involve supporting the patient in being opioid free, giving supportive medication for uncomfortable withdrawal symptoms. That's sometimes done on an inpatient unit, and that is sometimes easy to arrange depending on the facility and the resources available. There have also been other induction strategies that have been studied even more recently on an outpatient basis. But it would depend on the comfort level of the prescriber and the local resources, patient preference, and also, patient's history and comorbidities.
Well, that makes a lot of sense, obviously. When we're talking about this treatment, I understand there's probably a relatively high relapse rate. What factors contribute to relapse?
That's a good question. We do know that taking medications for opioid use disorder significantly reduces relapse to opioid use. However, many patients do continue to relapse even on medication treatment, and there are factors that increase that risk. For example, use of other substances like alcohol or other drugs, or having a co-occurring substance use disorder increases the risk of relapse to opioids even while on medication treatment. Also, having a co-occurring psychiatric disorder, particularly severe mental illness, increases that risk. And we know that having a history of heroin use or active injection use increases risk for relapse while on medication treatment. So it is recommended that all patients who are prescribed medication treatment for opioid use disorder be offered naloxone for overdose prevention and education around naloxone and support to minimize relapse risk.
Well, it occurs to me that if somebody relapses while they're taking buprenorphine, that's a very dangerous situation as opposed to naltrexone, which is going to prevent overdose, basically.
Actually, being on any of the 3 approved medications, I'm saying broadly, not specific formulations, reduces relapse risk to opioids and overdose potential. So even on methadone or buprenorphine, an individual is at greatly reduced risk of overdose, even if they use opioids on top of that medication treatment.
I see.
Methadone and buprenorphine, through different mechanisms, will still reduce the risk of overdose, even if a patient uses on top of that medication. Naltrexone is the true antagonist and will block it. And there are overdose risks with any medication, even if someone comes off of their naltrexone, for example. But it's always safer to be on medication treatment than not.
Okay, well, that certainly makes sense. You know, we're only as good as the most recent patient we've treated. And sadly, I had a patient who was on a buprenorphine sublingual who decided to celebrate an occasion and took an overdose and accidentally died. So I guess it is still possible.
Yeah, it's absolutely possible, even using other substances, non-opioids, together with their medication treatment. There are various factors that can cause overdose. Buprenorphine does have a strong binding affinity for the mu-opioid receptor and will block effects of exogenously administered opioids, reduce or blunt those effects. So it's not that it's impossible to overdose, but it's still reduced.
Yeah,
and there are certainly cases of individuals crushing and injecting the monoproduct together with benzodiazepines, for example, buprenorphine plus benzos injecting. And there are cases of deaths from that route.
That makes sense. Now, it seems like it might be a little complicated to do this. What sort of training does a prescriber need to be able to prescribe these medications?
In the case of buprenorphine, clinicians need to complete an X-waiver course to be certified to prescribe buprenorphine. And these clinicians, including physicians, advanced practice registered nurses, and physician assistants, would need to complete a waiver training course, which is provided by several medical specialty organizations. And fortunately, there are now free and online courses available. The requirement is 8 hours for physicians and 24 hours for PAs and MPs. And after they complete the training, they have to notify SAMHSA of the intent to prescribe and request a special number from the DEA, Drug Enforcement Agency, that gets linked with their DEA number.
I see. That makes sense. So it's not terribly difficult, but it is a barrier potentially.
It is a barrier to complete the course. It deters some providers from choosing to take the course, and it may in some cases send a message that this is a medication that's more difficult to prescribe. So it depends on the situation, but it can be a barrier to need to complete the course. However, over time, they've made it much easier by having these free and online options that you can complete at your own pace in various segments and save your work.
Now, I understand, or at least it used to be, that you would be limited to the number of patients if you were prescribing buprenorphine that you could have in your practice. Is that still the issue?
Yes. Initially, after obtaining an X waiver, for the first year, clinicians are limited to a total of 30 patients that they may prescribe buprenorphine at any given time. But after the first year, they may request to increase that number to 100, and in some cases, even to 275 if certain criteria are met. For example, having board certification in addiction psychiatry or addiction medicine, and that they practice in a qualified setting that can manage the process of managing opioid use disorder.
Mm-hmm. We have a couple of questions here that have to do with insurance and funding and things like that. And I'm assuming, is methadone funded federally or is it funded by private insurance? How is methadone funded?
Individuals who obtain methadone from an opioid treatment program may use multiple forms of insurance to have that covered. It's covered by Medicaid, by private insurance, and even for the uninsured, there are sometimes grant programs that will cover the cost of methadone.
Mm-hmm. And how about buprenorphine and naltrexone?
Increasingly, particularly since the opioid epidemic has gained more public awareness, there have been more insurance companies that are covering buprenorphine and naltrexone, private insurance companies, and also reducing the burden of prior authorizations to obtain these medications. So fortunately, we're seeing a trend in greater coverage of all three of the approved medications for opioid use disorder.
Well, that's certainly wonderful, again, considering this epidemic that we're facing, and especially the consequences here. I imagine this is something that there is a really clear cost offset in effective treatment.
Absolutely. And by requiring prior authorizations or by limiting insurance providers that will cover these medications, it also places a barrier on the clinicians who then are restricted in which option they have. It restricts our ability to individualize care and have a more patient-centered approach, and particularly during an opioid epidemic where we really need to reduce barriers to access of these treatments.
Right. Well, that certainly makes sense. Are the billing procedures for medication treatment challenging for clinicians? Is that something that they need special training on or they need to be concerned about?
My understanding is that the billing process for medication treatment varies, and in some settings, prescribers may not have that experience. It may be more straightforward, but in other settings, certain primary care settings, there may be challenges obtaining coverage for all of the comprehensive services that they may wish to provide. May be difficult to adequately bill for the specific and unique services, and some discrepancies in coverage options depending on the facility.
Well, that's a good point you raise. I mean, when we talk about medication treatment for opioid use disorder, I imagine it's like other conditions that we treat. You don't just throw medicine at the person. There's got to be lots of other interventions and supports and things you want to do at the same time.
Exactly. Having the ability to refer for behavioral treatment, which could be individual therapy or group therapy, and other social service supports, really could give an optimal, comprehensive strategy to manage the condition and also the comorbidities that are associated with opioid use disorder.
Yeah, it sounds very much like treating depression, for instance. You know, we don't just give people pills for depression. You talk about lifestyle changes and supportive therapy and cognitive behavioral therapy and the like.
Yes, the effects of the medication alone are very robust, but individuals are diverse and have unique needs, medical, psychiatric comorbidities, and may have different levels of experience learning relapse prevention skills and find benefit in different types of behavioral support.
Yeah, I sometimes liken what we do to treating diabetes or heart disease. You know, with diabetes, you don't just throw insulin at somebody. You've got to talk about diet and lifestyle and exercise. So really, best outcomes are always a combination of our medication and biologic treatments and support services. Now, we talked about billings and challenges, and one of the things I'm wondering is, at some point, I imagine a patient might be able to get off of methadone or get off of buprenorphine. Are there criteria for that, or is this considered just, indefinite treatment?
That's a great question. We view these treatments as long-term maintenance treatments because we know that relapse rates to opioid use are very high, even after treatment discontinuation. With that said, there are some individuals who successfully taper off of their medication treatment and they go on to remain abstinent. We don't have great predictors on who those individuals might be. As I mentioned earlier, heroin use, injection use are predictors of relapse, but we don't have a lot of great comprehensive tools to predict who might successfully taper off. So with that said, also, many patients do wish to eventually taper off, and there's suggestion from the literature and research that a slower taper is often more effective than a rapid taper. So if somebody would like to try to taper off, it's important to do that in conjunction with their prescriber and to do it slowly. And we don't rush to start that process. And we ensure that there's an informed consent and understanding that really with taper might come a return of cravings, some degree of withdrawal symptoms, and a higher risk of relapse and overdose. So many patients end up staying on these medications long term. The dose may change over time, their effective dose, and many of them really see an improvement in functioning in their lives.
So they can potentially be maintained indefinitely.
Absolutely. In many cases, patients are maintained indefinitely, or they attempt to taper and then they learn and they come back and say, you know what, I just don't feel as well. I'm not able to function in the same way, or my cravings have returned and I'm worried about relapse. Again, some individuals do taper off and they do very well. It's a smaller percentage, but we will work with patients if they would like to try that. And we see maybe what is the lowest effective dose that could maintain their stability.
But there's not necessarily an urgency, in other words, to get them off.
No.
Okay, that's interesting. My understanding originally, buprenorphine, at least the sublingual preparation, was kind of billed as something that would be for a period of time, and then patients would transition off. But I think what clinicians have found is that, as you're saying, really, very often we just continue it.
Absolutely. We continue it and we inform patients that down the line, we don't make that our treatment goal as the provider, but instead support patients who do wish to try to taper over time, and we don't rush the process.
I think that is really good advice. Thank you. Now, I'm also wondering, are there differences in, success rates or differences in your treatment decisions if somebody is coming to you as an oral opioid user versus an IV user?
There are differences in considerations. I'm thinking specifically about methadone versus buprenorphine. First of all, of course, to even consider methadone, one would need access to a methadone clinic, and these do not exist in every area of the country. So sometimes that's not an option, but some patients do benefit from the structure and support of a methadone clinic. They may benefit from the daily observed dosing that's required in the initial stages of the program and the extra counseling and support services that are part of that methadone clinic. That's not to say injection users or long-term opioid users cannot do well on buprenorphine. In an ideal scenario, if you have access to all of the treatment options, it's best to have that discussion with patients, learn what has worked in the past, what has failed, and then make a decision together where, of course, as the prescriber, you're giving your suggestions and input, because many patients can do well on any of the medications, but they may have a strong preference or some history that suggests that trying one over the other at this stage might be preferable.
Are there any data that people who have been abusing opioids orally versus those who are abusing them IV do better? Are the outcomes any different as far as we can tell?
What we do know from some studies is that having a history of heroin use or injection drug use is a predictor of relapse, meaning in some studies tapering off of buprenorphine, those with a history of heroin use were more likely to relapse at that stage, even though plenty of non-heroin users also relapsed.
Yeah, of course. But that does make sense. I mean, intravenous route is obviously much more of a rush than taking pills, for instance, is a slower.
Yes. And then duration in treatment is also a positive predictor that if you can stay retained in treatment longer, you're more likely to continue that success.
Now, I live in Florida, which unfortunately was the home of a lot of these pill mills. Where people were prescribing opiates willy-nilly, if you will. And so, of course, with this opiate epidemic that we're having, there have been a lot more limitations placed on prescribing. of medications, opioids, for legitimate therapeutic uses such as pain. The CDC has actually limited opioid treatment for short-term pain. How many days has the CDC limited in that right now?
It's a recommendation for 7 days.
So that's the CDC's recommendation, is to limit the prescribing to no more than 7 days. But certainly states can limit even more and put on more restrictions within that 7-day window. So I suppose that, you need to consult your own state's prescribing laws and guidelines. There's obviously issues here with interface with the criminal justice system. And one of the questions we have is, what is the disconnect between the criminal justice system and the public health system?
That's a very interesting question, because there's evidence, of course, that addiction is a treatable but chronic and relapsing disease of the brain. Yet, many individuals do not receive treatment, and providing treatment to individuals in the criminal justice system provides a unique opportunity to decrease substance use and reduce associated criminal behavior. However, many in this system do not receive treatment. So incarceration is not treatment. It is not a substitute for treatment. And we also know that after release from an incarcerated setting, rates of relapse and recidivism are very high. Yet, research has consistently shown that substance use disorder treatment can reduce substance use and drug-related criminal behavior.
I imagine. So, this sort of reminds me of treating SMI, severe mental illness, where our patients unfortunately end up in the criminal justice system rather than the mental health system. And so people I know are looking at innovative programs to try to integrate the two, or even do diversion programs.
Exactly. So an example is, drug courts that combine judicial supervision with drug treatment as an alternative to incarceration. And data suggests that outcomes are improved in terms of relapse and reduced criminal activity if they graduate those programs. So individuals who graduate those programs are less likely to return to substance use and engage in criminal activity. And there's also evidence that initiation of medication treatment for opioid use disorder prior to release from incarcerated settings is associated with reductions in relapse and return to criminal activity. Yet, many prison systems haven't been receptive to this approach.
That is a shame. And I imagine the punitive approach is never going to be as effective as the therapeutic approach. Now, one of the areas here that we haven't talked about yet are needle exchange services, or they call them syringe service programs. And I don't know, are those still in use? Are people still using needle exchange programs?
Yeah, there are syringe service programs, which are also referred to syringe exchange programs and needle exchange programs. And these are community-based programs that provide access to sterile needles and syringes, and they help to facilitate safe disposal of used syringes. And importantly, they often help link individuals in those programs to substance use disorder treatment programs. Depending on the program, it can vary. They may offer screenings for infectious diseases like HCV and HIV, abscess and wound care, and naloxone education and distribution. So these are important programs with data to support their benefit and their cost effectiveness.
I can imagine, though, a lot of people think, well, you're just enabling them with this.
Yes, and my understanding is that there are some restrictions in use of federal funds to actually pay for needles and syringes that could be used solely for the purpose of illicit drug use. So these are community programs that are run and determined at state and local levels, but there's some opportunity to use federal funds if certain criteria are met, but there's restrictions on how the funds can be used.
Well, it certainly makes sense to me when you describe it as potentially a bridge or a transition into medication treatment for opioid use disorder. That certainly makes sense. You sort of meet the person where they're at if they're not quite ready yet to stop.
Yes. Research has shown that these individuals who use these programs or who enroll in these programs are more likely to enter substance use disorder treatment programs, and they're also more likely to reduce or stop their injection use. So from a public health standpoint, these programs can be very positive in meeting people where they're at, exactly as you said.
Well, that's wonderful, especially when you consider, as we started off today talking about, the variety of options we have now. We certainly have a number of different medications. We have a number of different formulations or delivery systems. So it seems like we have more options than ever to try to help our patients who are struggling with opioid use disorder.
Yes, I agree. And it's very important that we've seen increasing approvals of new formulations of medication treatment options and slowly chipping away at some of the barriers to entering treatment, accessing treatment, having that treatment covered by insurance, and fewer requirements to have repeated prior authorizations that dictate the duration of treatment.
Well, you've certainly given me a lot of hope, and that is an optimistic place I think that we can end. I really want to thank you, Dr. Mooney, very much for this informative discussion. I have to say I learned quite a bit, and so thank you.
My pleasure. Thank you for having me.
Thank you for your participation in this NEI CME podcast episode. To receive your certificate of CME credit, please refer to this podcast's description page for a link to go online and print your certificate. This concludes the CME podcast presentation.